passion for changing the world is a hallmark of his career. As a physician and leader, he has recognized the need for good policies and has used his vision and energy to lead in a variety of healthcare organizations. He founded the Center for Rural Health at the University of North Dakota, served as a health advisor for Joe Biden's 1988 campaign, was a member of the Clinton Healthcare Task Force reform efforts, was Executive Vice President for International Healthcare with Perot System, and most recently Chief Strategy and Development Officer with Healthcare Services for Dell. Currently, he is in his own organization with CREO of Strategic Solutions. One unique fact about him is that he shares his birthday with two of his children, and they aren't twins. When I first met him, he was living in North Dakota. Since then, he's moved to Michigan, Wisconsin, California, London, Washington, D.C., and now he has residences in Washington and in Oregon, in D.C. and Oregon. He shared with us tonight that he is doing international consulting. And first he named 3 countries in South America, and then he named countries in the Far East, and then he named countries in Europe. So he's been everywhere, I think. So it's a great pleasure to welcome Dr. Kevin Fickenscher to share his wisdom with us on the new healthcare bill, Fact versus Fiction. Kevin.
Well, thank you. It's a real pleasure to be here this evening and have the opportunity to share some thoughts with you. I haven't been every place. I do have on my bucket list Antarctica. So I really want to go to Antarctica. And what's your name again?
Sarah.
Sarah? And I really want Sarah to go to China and teach English. So I was lobbying her already before the program started. I guess the other thing I would say is that my one claim to fame that Donna mentioned is that my 2 children, 2 of my 3, were born on my birthday, which was a great experience. When the second one was born, Kevy, they all have K names. Yeah, naturally, that's what we do. So it's Kylene, Kevy, and Kieran. But Kylene and Kevy were both on my birthday. So I made the front page of the National Enquirer. Alien doctor delivers own children. That's me. So it's a real pleasure to be here tonight and to come back to Wisconsin. Loved Wisconsin, loved the Green Bay Packers. I was so excited. I was in my little apartment in Washington, D.C. by myself, jumping up and down. It was quite exciting. Real pleasure to come back here and to have the opportunity to talk with you about American political theater. So with that, I'm going to jump in and share my thoughts and my perspectives with you. What I thought I would do is talk with you about, first of all, why are we having this big discussion about healthcare? Why is that going on in our society? So I want to talk about that. And then I want to talk about the politics of it all, because the politics of it are kind of interesting, particularly if you live in Washington, D.C. That's all we do is talk about politics. And then I want to do sort of an overview of the legislation as it was passed, the healthcare reform package, and then we can talk about the implications of healthcare reform. So that's kind of what I'm going to do tonight, and I'm going to give enough time at the end for what Donna pointed out is we've got discussion, debate, reflection, and understanding. So we're going to have some debate and reflection, and I'm welcoming anybody to give a counter point of view. Because there is a lot of point of views around healthcare reform. I believe, though, that we need to do something. And that's going to come through pretty clearly as I explain to you my perspective. So this is my metaphor for what's going on in healthcare. And this is a very famous Chinese or Japanese painting. It's a painting of a tsunami wave. And I've been using the tsunami as my metaphor for healthcare for about 11 years now. So I've been using it for a long time. It's not just because of what happened in Japan recently or what happened in Southeast Asia now 4 years ago on Christmas Eve. Why do I use the tsunami as my metaphor? And by the way, the letters up there are the anagram for the word tsunami. So you're going to see that anagram on a lot of my slides. So why is it that I use that? Well, Tsunamis are interesting because they're really caused as a result of a disruption that occurs in the surface of the earth. That disruption is basically a sound wave that's moving through water. And when you're out in the middle of the ocean and the sound wave goes by, you don't even know it. I mean, it just goes right by you because it dissipates into the depths of the ocean. It's only when the sound wave gets close to shore that it creates a massive wave of destruction that cannot be stopped by anything. There's nothing that you can put in the way of tsunami that will stop it. You can't build brick walls high enough. You can't plant enough trees. As we saw in the films of what happened in Japan, it just takes everything and pushes it on shore. Why is that my metaphor for healthcare? I believe that we have a bunch of things that started to occur in this country that occurred about 10 years ago, disruptions that started, that have been moving through the forces of our society and are creating a wave, if you will, a wave of destruction that is an imperative that we must address as a society. We have no choice but to solve certain problems in our society. And healthcare, from my perspective, is either number one or number two on the list. Because it's not sustainable what we're doing today. And I'm a physician, and I believe that everybody should have access to healthcare. I also believe that we need to be responsible in our society. So that's a real dilemma. How do we do that? That's one of the questions, and that's the debate that we need to have and that we need to engage in this country. So this is my metaphor, and I believe it's a very apt metaphor for what we need to do. Marcel Proust, this is my very favorite quote, said, "The real voyage of discovery consists not in finding new lands, but of seeing the territory with new eyes." One of the issues that we have within the healthcare debate is that we've got a lot of physicians who look at healthcare a certain way. We have pharmacists who look at it another way. We have nurses who have a perspective. We have politicians that look at it another way. And the problem is we need to take off the blinders. We need to start having an effective dialogue because healthcare is all around us. It is very much a part of the fabric of this country. We all expect that we will get access to good healthcare. That is an expectation. Does anybody want bad healthcare? I keep waiting for somebody to volunteer. No, that's not part of what we want. So the question becomes, how do we deliver that? And I believe that one of the issues is that we've all got our silo perspective on, and we're not looking at the territory with new eyes. And we're at a point where because of the tsunami wave effect that is occurring in the United States, it is an imperative that we sort of take off the blinders. So that theme's going to come across. So I'd like to tell you a story. I like to tell stories, as you can probably already tell, because I think that they're much stronger in terms of the message that they carry. Well, this is the story of a woman. This is a woman who climbed the mountains, and she became known far and wide as the best mountain climber in all the land. And she would get up every morning and she would go climb the mountain, and she became very well known throughout all across the land as the best mountain climber. She developed calluses on her fingertips. She developed very sinewy muscles. She had an ability to take her toes and put them in the cracks of the rocks and sling herself from one boulder to the next. She was really good. One morning she gets up and she sort of looks around the horizon and she says, "You know, I think I'm going to go over there. I've not been up on that ridge." So she, with all of her mountain climbing skills, she climbs up to this ridge, and she gets to the top of it, and she looks down and she sees something that she's never seen before. It's a flat mountain. And she looks at it and she goes, "Wow, I'm going to go climb that thing." So she climbs down to it, she gets down to it, she reaches out, she touches it. It ripples in all directions. She reaches out, she touches it again, it's moist on the fingertips. She touches it again, she smells it, it's sweet, it's wet. She leans back and says, "Wow, that's a different kind of mountain." all of her skills that she had developed over decades of working and learning how to be the best mountain climber, she jumped on this mountain. And very quickly, like within seconds, she was in deep trouble. And she barely got back to the shore because she didn't know how to swim in the lake. She was a great mountain climber. But one of the things that happened over the next couple of days as she practiced climbing this mountain is that she learned that if she moved her arms in a synchronous fashion with her feet, and if she took her breath at a certain way, that she didn't choke, she didn't breathe in water, that she actually could swim the lake. That's what's happening in healthcare. We have a lot of really good people who are really smart, who are great mountain climbers, who are looking at lakes and going, how do I swim in that pond? That's the challenge that's in front of us. It's the challenge for doctors. It's the challenge for nurses. It's the challenge for politicians. It's the challenge for state legislators. It's the challenge that's in front of us. How do we swim the lake? And I think it's a very important message that we got to learn how to swim the lake. We don't really have a choice, from my perspective. Why don't we have a choice? Well, the reason that we don't have a choice is that I think that I've had the opportunity, as Donna pointed out, to be able to travel around the world. And I can tell you right now that whether you're in Brazil or Mexico or in Malaysia or in Jordan, you pick your favorite country that you want to go to. There is really one or two issues that dominate the discussions in all of those societies. And those two issues are healthcare and education. Education and healthcare, healthcare and education. That's the discussion that's occurring around the world. The other thing that's interesting about those discussions in all of those societies that I've had the opportunity to visit is that there's three things that dominate the discussions about healthcare. It is those three issues. People want their health care at low cost. Actually, if they can get it for free, that's really nice. Right? Does anybody want to have expensive health care? No, that's another one that I keep looking for. They also want quality. They want, I always say good quality. Actually, they want perfect care. Does anybody want to go over here to Agnesian? Bob's here, the chief executive officer of Agnesian, and get an infection at the hospital? I mean, Bob will take your name. We'll sign you up right now. No infections. So, no infections. So we want not quality health care, we want perfect health care. And I've been in the hospital. I want things done right. And we want it right now. We don't want to stand up. Who wants to stand in a line and wait for Dr. Fickenscher to show up, for crying out loud? I mean, really. I'm busy too, Dr. Fickenscher, right? So cost, quality, and service are the three dominant factors that sort of permeate the discussion around all of healthcare. Now, the other thing that's kind of interesting about healthcare, I've spent a lot of the last 15 years working in the IT space, is that we have had an interesting phenomenon begin to occur. We are moving from an information theocracy. Hi, my name is Dr. Fickenscher. I'm really smart. I went to medical school. And I've been looking at your problem, and here's what you should do. What's your name? Alice. Alice comes in the office. She says, Dr. Fickenscher, I looked you up on the web last night. Dr. Fickenscher, I noticed that you're not in the upper quartile of physicians who practice at this particular hospital. As a matter of fact, Dr. Fickenscher, it says here that you're in the bottom quartile. Dr. Fickenscher, would you please explain why I should let you touch me? Now, as a physician, I can tell you that it is not uncommon in today's world to have people come in who have a problem. Let's pick prostate cancer. Who've gone on the web and looked up what they do at the MD Anderson down in Texas and say, so Dr. Fickenscher, do you follow this protocol? This is considered the best protocol in the world. Do you do that? Sure. That's the kind of world we live in. We have moved from an information theocracy to an information democracy. It is challenging the very fabric of how we organize healthcare. It is no longer about Dr. Fickenscher being a nice guy and going to the right medical school and having a degree and shaking hands and saying, trust me. It is, I looked you up, I have the data, and we need to have a discussion, right? So information theocracy is changing the whole fabric of the relationship that you have as a consumer with a provider like myself. And I think that means that we need to rethink how we're delivering care. And I think it's a real challenge for those of us in the healthcare industry because we have to go from this to this. We have to learn how to swim the lake in that new world. So what are some of the global forces that we're seeing that are really shaping what's going on here in the United States? When I talk about global forces, I'm talking about forces that are occurring overseas, but that are really shaping our discussions in this country. Because we don't have as much control as we used to have. After World War II, the only economic game in town was called the United States. We were the engine, the economic engine of the world. There was no competition. Do we think that we've got some economic competition today? I'm seeing a lot of nodding heads. I mean, you've seen it right here in Fond du Lac. You've seen it with the businesses that have changed their structure, how they have employed people over the last 10 years. You're seeing it. We're seeing it all across the country. So we have an economic challenge. We're also seeing the fiscal pressure on governments. It's not just our government. If you look at Europe, oh my gosh, all the economic pressures that they're facing throughout the European Union are really, very, very challenging. And it's also in the world, in the places that are developing fairly rapidly, like Brazil. Brazil is going through a period where their economy is exploding, and they're trying to figure out how to keep up with the expectations of the people that want to have services like healthcare. How do you put in place the systems? How do you build the hospitals fast enough? How do you provide the clinics? They've got all sorts of challenges as well. And so we've got that free market competition. We've also got simultaneous diversity as well as integration that's going on, cultural. In the United States, in terms of healthcare, what we're seeing is very much large-scale consolidation. We have gone through a period actually over the last 20 years where if you look at the pharmaceutical industry, 20 years ago, there were about 22, 23 different pharmaceutical big companies, and now there are 7 that dominate the drug industry. We're seeing, I remember 30 years ago when we had lots of individual hospitals. We were talking about it at our table tonight, that in fact in Milwaukee there were, 10 or 12 different hospitals, and now you basically have, I think, 2 or 3 systems, okay? So we've seen consolidation, but the consolidation isn't over there. It's going to happen more from my perspective. We're going to see more of it. And we're going to see it on both the hospital side as well as the physician side. We're seeing the breakdown of traditional boundaries. Who would have predicted? I didn't predict that Walmart was going to get into the healthcare business. Who predicted that? Anybody here? I missed it. I once talked about how the fact that I thought Sears was going to get into the healthcare business. They were going to remove the carpet store, putting, a clinic. They were going to give beepers to people, let you go buy your stuff in Sears, and then beep you 20 minutes late and let you buy stuff, things like that. Somebody from Walmart must have been listening because they actually do that. I mean, that's how their business model is. Now, they don't take care of everything. You can't go to Walmart and get your chest pain managed, but you can get the low-hanging fruit taken care of, and you can get it done fairly quickly, and you know what? It's pretty darn good. I've actually tested it out. I've been to Walmart in Las Vegas. I've been to Walmart in Miami to test it out, to take off the blinders and say, what's going on here? They actually do a pretty good job, and it's cheap, and it's consistent. It's the same in Miami as it is in Las Vegas. So they're taking the blinders off. We're seeing cross-industry convergence. We're seeing the rising tide of technology. Technology is one of my favorite things. because I really do believe that if we use technology appropriately, if we use it appropriately, it will help deliver better health care. If we do it inappropriately, where we put technology on top of technology, it makes it more expensive and it actually denigrates our ability to deliver quality health care. But technology is an important part of the change that's occurring. I would also submit to you that there's a phenomenon out there in the world that most of us, I'm 60, I just had my birthday 4 weeks ago, so I'm in another generation now. And most of us of my generation don't really get social media. When I ask my colleagues that are 60, how many of you are on Twitter, I don't get many responses that they are. I'm one of the few Twitter guys who's 60. I'm on Facebook. I'm doing all this kind of stuff, not because I necessarily wanted to. As a matter of fact, my company forced me to do this. But I did it because I needed to learn, and it's been fascinating. And I would submit to you that social media is a phenomenon that we don't understand in healthcare, but is going to change healthcare. How's it going to change healthcare? You know, one of the most effective ways of getting diabetics to take care of themselves is to get messages on a regular basis. So using Twitter to send messages to diabetics to say, have you tested for your glucose today? Simple little things like that. In South Africa, they have learned through the use of Twitter that they can reduce the incidence of AIDS in the population that is at risk for AIDS. Now, social media is something that we don't understand in my generation. A lot of healthcare leaders don't get it. Is it going to change healthcare? I think so. So we have technology things that are changing, and workforce is changing. And I'm going to talk more about that in a little bit. But, you know, do you people know who your radiologist is? Does anybody, who's your you know your radiologist?
I work in medical imaging.
You work in medical imaging. Are you the only one? Is there anybody else that knows who their radiologist is? Does anybody care? We got somebody who cares. Okay, that's two. There must be 100 people here. Oh, three. So we got a 3% that care until the bill comes. Now, why is that important? Well, it's important because I was on the plane about a year ago, and when I get on airplanes, I have this habit that I engage in, which is I generally sit on the aisle. Matter of fact, I fight to sit on the aisle. I generally cross my legs towards the aisle. I lift my shoulder, and I give a very clear message of, don't talk to me. Very clear message. It's a very consistent thing that I do. On this particular time, I was Dr. Chatty for some reason. And I turned to the guy next to me, and I start talking to him. And we're flying from San Francisco to Washington, D.C., and I said, so, you know, what are you doing? You going to a meeting? He says, no, I'm just passing through Washington. I said, really? Why are you passing through Washington? He says, well, I'm going on to Paris. I said, oh, Paris, I love Paris, one of my favorite cities in the world. What do you do there? And he says, oh, I practice medicine for the folks back in San Francisco. I said, what? Well, what he does, he's a radiologist. He lived in San Francisco for 20 years. He moved to Paris, and now he does the night program for the radiologists back in San Francisco. So he lives in Paris, and he practices in San Francisco. I asked him if he wanted a family physician to join his practice, and he didn't have any room. So darn it, I couldn't join him. But, you know, that exists. As a matter of fact, about 6 months ago, one of the preeminent medical schools in the United States, after 6 o'clock, their films are now read in Bangalore, which is in India. Now, they've got quality controls. All of that's built into place. So if you don't know your radiologist, that's okay, because they probably don't live here after 6 o'clock. So that phenomenon is creating a globalization of our workforce. And, you know, I'm using that as an example, but that's happening all over. It's happening in lab services. It's happening in back office functions for hospitals. It is part of the way work gets done. And it's not just healthcare. It's happening in all sectors of the economy. So what are the forces that are affecting? Well, the first one is that clearly we're in a global economy. I think all of us would agree with that. I know that you've seen the effect of that here in Fond du Lac. The other thing is that we're seeing very significant pressure. I mean, you can't pick up the newspaper anymore where there isn't a discussion about the economic pressures that are being foisted on governments around the world, whether it's local governments in Fond du Lac, or state governments in Madison, or federal governments in Washington, D.C., or the European Union. The front page every day is about the economic stresses that are affecting those countries. We also have an issue around the boomers. Now, I'm a boomer. I'm on the leading edge of the boomers. I'm not at the exact front end of the edge, but I'm really close to the front in terms of my age. Just turned 60, as I told you. One of the things that's interesting about boomers is that we have literally changed every part of the age period that we were in. Okay? So when we were little kids, we bought red wagons. And then we learned that we could get on two wheels, and we bought Schwinn bicycles. And then we went to college, and we did some other things. We won't talk about that. Yeah, we protested, right. Mm-hmm. Yes. And then we got into our mid-careers, and we started to generate income, and then we got into investments, and now we're hitting 60, and you know what happens when you get together with a bunch of 60-year-olds? They sit and talk about their aches and their pains, and what pills are you taking for this, and have you seen the doctor for that? And I mean, it's really interesting to be in a conversation with a bunch of 60-year-olds. It really is. Fact of the matter is, I have consumed more healthcare dollars in the last 3 years than I have consumed in the previous 57 years of life. And you know what? I'm a typical boomer. I see a bunch of boomers around the room nodding their heads. Yep, that's happened to me. We are demanding, and there's a whole bunch of us. Not only that, but if you look at the population of the people who provide services, a lot of them are boomers. I don't know if you know this statistic or not, but it's really interesting, is that 1/3 of all physicians in the United States, 1/3, are going to either retire, become disabled, or move on into something else over the next 10 years. 1/3 of all physicians in the United States. Do we have a workforce problem? Oh yeah, we're starting to, there's lots of chatter in the healthcare professions about how we're going to solve this problem. And you know what? It takes a long time to produce a family physician. It doesn't come easily. So how are we going to do that? So we have a problem there. The other issue is, in terms of our physician population, is that fully 25% of all the physicians in the United States were trained in another country. So in other words, we have really solved our workforce problem on the backs of other nations. And the two primary nations that we solved the back on are India and the Philippines. Having been to Manila, having been to Delhi, having been to Mumbai, I can tell you that economically, there's no reason to come to Los Angeles or Fond du Lac or Madison or any place else. There's lots of economic opportunity if you're a physician and you want to live in Delhi, or if you want to live in Manila. That didn't used to be the case 20-some years ago, but that's the case now. So the economic imperatives that really fostered those physicians looking to come to the United States are not there as strongly as they used to be. We got genomics. When I went to medical school, we had a 4-week course in genomics. That was it, 4 weeks. Well, you can't effectively practice medicine if you don't really understand genomics. It's very much becoming a part of the fabric of how you think about what we're delivering, what the healthcare problems are, et cetera, and how you treat it, et cetera. The internet has clearly changed everything, and then I think another force that is very much a part of at least the culture of the United States is that people extrapolate their experiences in other things to healthcare. So, you know, the fact that you can go stand in line and get your burger real quick, and you can do it within a minute, means that you take that mentality and you come to the clinic and you say, why do I have to wait for Dr. Fickenscher? It's like, I don't want to wait for him because I know what the problem is. I'm just coming here because I have to, right? The other thing that's interesting about that particular phenomenon is that the people that go to McDonald's are different than the people that go to Ruth Chris. The people that buy Chevys are different than the people that buy Lexus. And in healthcare, we haven't figured out that people are different. We treat everybody the same. We have the same process that we use, and we stamp it out. So there's a lot of learning that needs to occur within the industry on how to interact with consumers who are becoming very conscious of what they do. This is a slide that I've been using for 20 years. I update it about every 18 months when the data comes out from the World Health Organization. But it's really interesting. I do update it every year, but it hasn't changed all that much. It hasn't changed in terms of the slope of the curve. And what this is on the left-hand side, it's the percent of GDP of healthcare cost by GDP, and across the bottom, it is the per capita income. And so basically what this graph shows you is that as the per capita income goes up, the amount of money that a society expends on healthcare services goes up. What's interesting is that I put on this particular slide the two red spots. The one that's down there below is the United Kingdom. They had a big bump in terms of their expenditures for healthcare because Tony Blair, when he was the Prime Minister, decided that they needed to pay physicians more so that they could, attract them and keep them in the UK, et cetera. So they had this big bolus effect that occurred over a relatively short period of time, so they spent a lot of money. And they went from basically about 6.5% of GDP in the UK to just about 9% of GDP last year, which is the most recent statistics. There is this other country that's over here on the far left, is sort of above the curve, which a number of years ago, not too many years ago, actually it was 7 years ago, had a percentage of GDP at around 14% that is now at 18.3%. That's us. Now, why is that important? It's important because all the goods and services that we produce in this country are competing with goods and services that are produced in other countries. To the extent that we have a differential where literally we have a 4% difference in terms of our GDP cost, that is added on to the cost of goods and services. So that means if you make a pair of shoes in the United States at Allen Edmonds, my favorite shoe company, they have to become more efficient, they have to become more productive than the folks who make shoes in India. And if they don't, they go out of business. That's the phenomenon that we're in today. So healthcare cost is one of the biggest issues for most people that are in business. It is a driver for the discussion. And the other thing is that this also gets reflected in this slide. So what I'm showing you here is a really interesting slide. It's the percent of debt to GDP for the United States. And what you'll notice is that we've sort of kept it around 50-some%, except for that spike in 1950, which was the result of World War II. In World War II, we went into debt to pay for our expenditures for being in war. And then after World War II in the 1950s, we had to pay for that, and we got that debt back down. But look where it's gone since 2000, the year 2000. It's gone up to 98%, which was last year, the debt to GDP ratio, and it's projected by 2020 to go to about 115%. Now, if that doesn't get your attention, what do you think it was for Greece or Italy? 105%. We're on the same road that Greece is on. That's my message. And part of the reason we're on that road is because of healthcare. Let me give you another statistic. In 2009, in the United States, the federal government generated $1.2 trillion in taxes. $1.2 trillion in taxes. Now that's a lot of money by any estimation, right? In 2009, that same year, Medicare, Medicaid, Social Security, and interest on the debt consumed $1.3 trillion. In other words, we spent on 4 things: Medicare, Medicaid, Social Security, interest on the debt. We spent more on that than we took in the entire tax base of the federal government. Now, so how did we support the military? How did we support the arts and humanities? How did we support schools? Well, we borrowed the money. Who did we borrow it from? Well, we borrowed it from China. They were willing to lend us money. Japan, do we think that Japan's going to want to lend us money now? I think they got some issues that they got to deal with back home. Europe lent us a lot of money. They're not in a really good position to do that. And then there was the oil countries in the Middle East, which came in fourth at a distant fourth, I should add. So we borrowed everything from these other countries, and that's how we paid for it. And that's the reason our percentage of debt to GDP is going up, is because we've been borrowing. Now, I'm a big believer in healthcare access for everybody. I mean, I really do believe that. And I think we need to figure out a different way of making it work. I think the system is broken, that it's incumbent upon those of us who have a concern, whether it's as individuals that are consuming the services or those of us that are providing the services, that we've got to figure out this dilemma, because if we don't, we're headed to there. If you look at state budgets, the reason there's lots of angst here in Wisconsin is that about 1/3 of the state budget is consumed by healthcare costs, maybe a little bit more than 1/3 actually. That's the reason there's an issue. That's the reason there's an issue in Illinois. That's the reason there's an issue in Texas, in New York, in virtually every state. There's only one state in the union, my home state of North Dakota, that has cash positive this year. Every other state is underwater financially. It's a question of how much. So I'm trying to get people's attention on this issue. Have I got your attention a little bit, you know? And it's not just a throwaway issue. It's not like, well, you know, I'm going to take care of myself because I'm a boomer. So let's keep Medicare the way it is, and let's let Sarah solve the problem for herself. Okay? Good luck, Sarah. So there's the line, and you can see where we're at. Now, the other thing that's important to understand about this is that we are currently, as I said, at 18.2, 18.3% of GDP going for healthcare costs. It's projected over the next 3 to 4 years that we're going to go to 20.5% or even 21%. Now, what that means is that we have to come up with 2.5%, 2 to 2.5% from someplace else. So the question becomes, if we're going to spend 21% on health care, do we take it out of roads? Do we take it out of sewer systems? Do we take it out of bridges? Do we take it out of education? Let's do what California did. Let's do away with support for foreign languages. That's a really smart thing to do in a global economy. That's the choices that we're at. We're at a point where we got to make some choices. And that's the dilemma that we have that is really causing lots of foment. Lots of foment. The other thing that's happening is that all of us, I don't know about you, but I got a memo here last year from Mr. Perot, who I really adore. He's you know, I would do my Perot imitations, but I don't do that anymore. But he's a wonderful guy, and he actually, we all have our example. No, I won't go. But anyway, we got this really great memo that said, Dear Kevin, we all got it. Everybody got it. It was very personalized, you know, first name. Dear Kevin, it's so good to have you as part of the company. You're really contributing a lot. We know that you, as a concerned member of the Perot family, would like to help the organization so that we can increase our shareholder value so that one of the ways we've determined that we can increase shareholder value is by allowing you to have the opportunity to pay more for your health care insurance. And I said, gee, Ross, thanks a lot. I really appreciate that. I'm really doing my thing for the company. So all of us, and that's what this slide shows, are reaching into our pocket, and we're having to come up with our dollars to pay for healthcare services. Now, I don't know about you, but I'm starting to pay attention. 2 weeks ago, for the very first time, because I don't usually do this, I usually let my wife handle all this, but for this particular issue, I happened to take charge of it. I was going to be responsible. I went and got my medications filled. Well, I'm supposed to send them into SureScripts, which is, you know, this company that you send things into, and then 5 weeks later you get your medications. And I wasn't going to do that. I was going to go to the drugstore, and I was going to get it right now. After all, this is the way I want my service. So I handed in my script. They said, well, you know, you can't do this through your insurance. I said, I'll pay cash. I was being very impatient. $382 later, $382 later, I was choking. I've never paid attention. Do you think that all of a sudden it got my attention when I had to pay $300? I mean, that's a lot of money. That got my attention a lot. And I started to think, well, gosh, if that's what this costs, what do all these other things cost that, you know, my family's consuming? All of a sudden, I am paying attention to the dollars that are coming out of my pocket. Now, I didn't used to do that because, you know, it was handled some other way by insurance, right? So this is an important phenomenon that is stimulating all of us to become very cognizant of our health care. By the way, there is a point to this whole story. I'm going to get to what's going on in Washington. I mean, just give me a chance. Who do you think is the individual in the last century that saved more money in the shortest period of time in healthcare costs? Any guesses? Who?
James Salk.
Okay. Any other guesses? A lot of people think it was this guy. This is C. Everett Koop. Dr. Koop is a wonderful gentleman. He is the guy who was the Surgeon General when we issued this smoking report. And a lot of people feel that, you know, the smoking cessation rate went down every year until last year. Last year, it went from 19 to 20% of the population smoking. It started off at 44%. That's a heck of a drop over the course of, you know, a period of years. And that's clearly had an impact on the health of the population. Our whole attitude as a society about smoking has changed very dramatically. But it wasn't this guy. It was this guy. Oh, come on, Kevin. Front page of the National Enquirer, and now you're saying Elvis is saving us money, you know? So, why did that happen? Well, on October the 28th, 1956, does anybody know what happened? Elvis Presley went on a simulcast on ABC, CBS, and NBC, and he got his polio vaccine done by Dr. Salk. The immunization rate in the United States for polio went from 1% to 80% in 6 months. More importantly, we were at that point in society where a lot of people were not getting their vaccines, and all of a sudden people started to get not only polio, but they got their measles, their mumps, their rubella, and we wiped out a lot of infectious diseases in this country in a relatively short period of time. That probably had more effect on the cost of health care. It used to be, I mean, when I was a young orderly at the hospital, we used to have the iron lungs, you know, for the polio victims. You know, those are relics. So, in fact, he had a big impact. And one of the things that I often point out is that we need to find Elvis. That's what we need to be doing right now. We need to find somebody who can help us go down that route so that we can save dollars. So what is it that people really want? Well, this is what people want. This is what providers want. This is what planners design. This is what regulators want. This is what the politicians pass as law. Yeah. This is what gets implemented. This is what the media reports. And this is what the government funds. This is why we're having lots of debate. And this is what the public understands. Now, in 7 slides, I have just described American healthcare. So, I mean, I could have started with this and we could, be over and we have the debate. So let me jump very quickly. I'm going to go through this next part rather quickly, but I want to cover a couple of points, which is, about the healthcare reform package that passed in Washington, D.C. just over a year ago on March the 23rd. We had the first anniversary party. Well, it wasn't really a party. Nobody came. But we had the 1-year anniversary of the passage of the reform legislation. Now, we have 2 gentlemen that sort of led the charge. Actually, they didn't lead the charge. They sort of hung back, and they let Congress sort of deal with this issue. They didn't ever submit their proposal. And we have all these other players that were involved as well. I would submit to you, though, that we would have had an entirely different debate if this gentleman had been in the United States Senate. Now, why do I say that? Because if you look at the legislation that has been passed in the United States on health care, Ted Kennedy's name is on more pieces of health care legislation than anybody else. Not only that, who's his partner in that? Orrin Hatch. Orrin Hatch was his best friend. Orrin Hatch is a conservative. Let me underline that word, conservative senator from Utah. And he and Ted Kennedy did more legislation than any other set of senators in the history of the United States Senate on health care. And if Ted Kennedy had been in the United States Senate, I'm convinced that we would have had a different discussion. He was the master of the compromise. Rather than forcing things through, he would have figured out a way to make people more or less come together. That was his thing that he was really quite noted for. That's the reason he was so respected on both sides of the aisle in the United States Senate, despite the fact that he was a very liberal senator from Massachusetts. So I think we would have had a different discussion. Unfortunately, he wasn't there, and so the discussion has been more acrimonious, I guess is the right word. We also had our industry advocates. We had the doctors, we had the insurance companies, we had the hospitals. Everybody got involved. Matter of fact, it has been suggested, and it actually has been documented, that this is the most expensive piece of legislation that has ever passed the United States Congress. And it's because we had more than 1,750 companies get involved in lobbying. We had over 4,500 lobbyists involved. I was not one of them. And you see the list there. I mean, we had a lot of people sort of touching this particular piece of legislation, and it created this behemoth called healthcare reform. At the end of the day, basically what happened is that you had in the House bill a bill that said we're going to cover 17 million additional people, and in the Senate 31, and they ended up sort of in the middle. And then on the cost side, the House was going to spend $1.2 trillion, and the Senate was going to spend $849 billion. It came out at $952 billion. Actually, with the Congressional Budget Office, they're now saying it's just slightly over $1 billion, but there's going to be all these savings, et cetera. So the notion that we're going to spend this money is there, but there's also a projection, and the Congressional Budget Office agrees with this, that over the ensuing decade that we will save, trillions of dollars. So basically what happened is that all of the issues related to coverage, individual mandate, employer mandate, revenue sources, insurance reform, and Medicaid expansion passed, and the public option was not included. So I'm trying to distill down a very complex 1,100 some pages, 1,173 pages or something like that, document, trying to distill it down in a relatively short period of time. Basically what happened is that as I said, we're about $952 billion It's just slightly over $1 billion now projected. About half that money is going for Medicaid and children's health programs, and the other half is going for subsidies to individuals so that they will buy insurance. Now, this is a program that was actually tried in Massachusetts, and it's actually been very successful in Massachusetts. Massachusetts has gone from roughly 85% of the population insured to now they have 97.5% of the population insured in Massachusetts. The doctors like it, the hospitals like it, the public likes it. So in Massachusetts, at least, it has been a relatively successful kind of model. It is causing economic stress. Massachusetts is trying to figure out how to balance its state budget just like everybody else. But generally, what it has done is it has moved people that were uninsured into the insured. Now, that was something that the insurance companies really pushed on, that they wanted to have. Why did they want to have that? Well, if you don't have everybody insured, then, you know, you basically have a situation where actuarially it's very difficult to predict what the population is going to do. And so when you have this 32 million people of uninsured over here, basically what happens is that, and I'll use a local, I mean, you know, this is what happens at hospitals, is that the local hospital, like Nijian, they charge more to the people that are insured than they do to cover that cost. Somebody's got to pay for it. I mean, it's not free, right? So there's a shell game that goes on in healthcare. Well, this was intended to take away the shell game. We're not going to have that anymore. That was the intent. Now, this whole thing has been debated, and we now have the individual mandate being challenged. There were 26 states that filed Friends of the Court briefs in Florida. In Florida, Judge Vinson, who was the person there, the judge, he said, throw out the whole thing. Individual mandate doesn't apply, it's unconstitutional, and as a result, the entire legislation is thrown out. In Virginia, the judge he said the individual mandate was unconstitutional, but he didn't throw out the whole law. Now, what's interesting is that the Supreme Court rarely decides to take on a case before it has gone through the appellate process. The Supreme Court has just recently announced that in mid-April, they are going to hear the case from Virginia. Why is that important? It is a signal, I think, that the Supreme Court has determined, well, the whole thing is not unconstitutional. This individual mandate may be. Now, what's particularly interesting if you're a court watcher, and I watch the politics of what goes on in Washington a lot, is that really what's fascinating about this whole discussion that we're having about healthcare reform and the whole healthcare legislation and all the debate in the country is that it comes down to one person's opinion, and that's Justice Kennedy. The other 8 members of the Supreme Court, there's 4 of them over here and there's 4 of them over here. That's pretty clear. And you got Justice Kennedy in the middle, so it depends on what he thinks. That's my perspective. Now, that's my prediction, is that it's going to be a 5-4 vote, one way or the other. And it will depend on what Justice Kennedy, Anthony Kennedy, decides. It's fascinating that probably one of the most important issues that we are facing as a society, I think, economic issues as well as societal issue, as well as important to a lot of us who are concerned about healthcare, is going to be decided by one person who happens to sit in the Supreme Court. I think that's fascinating. We'll see what happens. That's going to be discussed in April. They said that they're going to take hearings on April 15th, so we'll have to wait and see. Now, so we've already talked on the left-hand side about where the money comes, or where it's going. On the right-hand side is where it's coming from. And again, sort of a 50-50 split. Half the money's coming from spending cuts, and half of it's coming from new taxes. Now, the cuts are coming in education, long-term care, insurance premiums, Medicare Advantage programs, et cetera. Here's the list of where the money comes from. So you can see that $196 billion comes from reduced Medicare scheduled payments. So in other words, Mr. Foley here locally is going to have a reduction in the amount of Medicare dollars that are going to be flowing to the hospital. So he's going to have to figure out how to become more efficient. That's what this legislation is telling him. We're also going to see Medicare payroll taxes increase. So those of us who pay Medicare payroll taxes, which is all of us, we're going to have a portion that goes up. So we're going to pay more taxes on that. So you can see the list there. I'm not going to go through all of them. My favorite is the last one, the indoor tanning tax. My daughter, who is 21 years old, who lives in Portland, Oregon, called me up and said, "Dad, did you know what they're going to do about indoor tanning?" And I said, "Kieran, yes, I do, and I think it's a really good thing." She said, "Oh, Dad, you know, I can't believe this, and it's going to cost me more to get my tan." It's like, oh boy, the world should be so tough, you know. And you can see where all the other money coming from. But basically, through the cuts and through the taxes, they came up with enough money to pay for the program. So what the big piece of this is Medicaid expansion. And what they did is they are going to increase the enrollment in Medicaid by 16 million. So the other portion, the other 10 or 15 million people come from those who are not Medicaid eligible, but who are going to be part of the individual mandate. So this is where that whole individual mandate discussion becomes very important. But 16 million people are going to be covered under this particular program. The feds have decided that for the short term, they're going to provide the money. And in the out years beginning in 2014 and beyond, the states will have to pick up the cost for that on a graduated basis. The other thing that they said is that the states, there's a phase-in, if you will, of the funding for the states with expanded eligibility for adults, and they can't reduce the benefits program. So in other words, you can't come up with money by reducing benefits. And the reason they did that is that, you know, that's what a lot of the states would have done, and we would have seen a splintering, if you will, of the Medicaid program. The other thing they did is they said we're going to increase the payments for primary care physicians because they're not paid very well. The employer mandate basically says that if you have more than 50 employees, you're going to have to provide insurance or you're going to have to pay a penalty. And the idea was to encourage employers to provide insurance. Large companies like Dell provide insurance to all of their employees. It's the smaller companies that sort of electively either provide it or not. And the intent was to get the smaller companies on board and to give them a subsidy, a tax subsidy, so that they could do that, again, in the first couple of years, so that in the out years is when they would start to pick up the costs themselves, or predictably pass them on to us, which I think is likely what's going to happen. But the issue becomes, for all of us, is do we want to have the current system where basically we force Bob and all of his actuary people that work for him and all the financial people to figure out a way to cover up the cost of all the people that come in the hospital into the emergency room, which is the most expensive place to come in, and get services and pay for that? Or do we want to have all of us ante up a little bit more and have everybody on an even keel? That's the question. And that's the debate. And the debate is not should we do that, it's how should we do this, I think, is the debate. At least that's my argument. Some would say, no, we don't need to do this at all. I would say that as a society that cares about the people that live here, that we should care how people get access to health care. It's like education. Are we going to take away education? I don't think so. I think health care is one of those things that is part of what we should be doing as a good society. The question becomes how. How are we going to pay for it? The individual mandate is the big kicker here. There's lots of details here. I'm not going to get into that. There's a sliding scale that applies. Again, the intent is to get all of us who aren't insured to insure themselves. So, for example, I see a lot of young people here. I would bet you that a lot of the young people that are here are not insured. And it's because when you're young and you're 21 years old, you're invincible. I mean, there's nothing that's going to get me, right? Unless you crash your motorcycle. Then you're going to be very expensive. And if it's just one of you, that's a lot of money. Or if it's two, that's a whole bunch of money. The rest of you are pretty healthy, you're right. But it's those folks that need to get insured. That's one group. It is the folks that are in the middle there who are working, but like my brother, my brother, until he passed away, was a working guy, and he made about $22,000 a year. He wasn't eligible for Medicaid, and he had to pay for his own health insurance down in Arizona. So, you know, he's one of those guys that was uninsured until I got him to get his insurance. So that's the kind of issues that we're facing, and that's what was attempted as a method for trying to solve that problem. And the way they're going to do it is by creating the exchange. The exchange is a mechanism whereby insurance companies will bid to be part of the exchange to offer their insurance package, and they have to offer it as one of four or five, actually, packages. They can offer the bronze, silver, gold, platinum. You kind of know what that is. Platinum is really good coverage. Bronze is okay. And they also have a catastrophic that would be available for those people that are up to age 30. That's what would be offered in the exchange, and you could go online and you could compare Blue Cross Blue Shield of Wisconsin against Cigna, against Aetna, against whoever happens to offer their packages in Wisconsin, and you could do that online and, you know, do some comparison. The exchanges would be run by the states, and it would be organized by the states. That's where one of the debates is at the present time. And there would be, you know, basically very little, well, the other thing that would happen here is that if you had a pre-existing condition, that couldn't be considered. So, for example, I'm very excited about that. About 2.5 years ago, I was diagnosed with bladder cancer. Now, most men don't get their diagnosis of bladder cancer until it was too late. I was lucky. I got mine very early, stage 1. And so I go in for my office cysto, hate the exam, every 6 months, and I'm clean as a whistle. But I couldn't get health insurance if I wanted to. Now I'm starting my own little company, and I had to go out and buy health insurance. So for me to buy health insurance for just myself, forget about my wife and anybody else that I want to insure, just for me, the insurance company is going to charge me $20,000. Now that's not what most people have to pay. I mean, if it's $6,000, that's a lot. $20,000 is ridiculous, but that's what they're charging, and it's like take it or leave it, Kevin. Take it or leave it under the current situation. Now, when this law kicks in, they won't be able to do that to me. They won't be able to do it to all of you who have pre-existing conditions. So all of us who have pre-existing conditions are very excited about that particular provision. We think that that's fair, because isn't that what insurance is all about? We share the risk. What else? Transparency is going to be very important. There's a whole bunch of things that are going to be measured. So the quality, the provider networks, the payment procedures, denials, coverage, all that stuff's going to be transparent. And Bob is going to have to report on that, and you're going to be able to look at Bob's results compared to Oshkosh, compared to Milwaukee, compared to Marshfield. You'll be able to look at that and say, you know, how are they doing here locally? And one of the things is that if you look at the data on healthcare, is that when you suddenly have data that becomes transparent, it's amazing how quickly people improve. It's an interesting phenomenon in healthcare. Once you do transparency, doctors really start to improve very dramatically. There's going to be money put aside, $250 million for fraud. And there's going to be standardization and simplification, which is something that a lot of docs have been calling for. The one thing that's missing from the legislation is that there's nothing about malpractice reform. That's not included in this legislation. And a lot of us feel that they should have included that. Now, and finally, there's the Cadillac tax. In other words, if you make over $250,000 a year, then you're going to have to pay more. I'm sorry, the Cadillac tax is on insurance. There's also the Medicare payroll tax that if you make more than $250,000 as a family, you have to pay more into the Medicare program. You go from 1.5% to 2.33% of your gross income going in as taxes. So those are some of the details. But what I would tell you is that I've been predicting since a year before this passed is that we were probably going to pass something, and that what would happen over the next 5 years following is that we would tweak it, which is exactly what is starting to happen. We're starting to tweak it. Now, why did I predict that? Well, if you go back to 1965 and 1966, when we passed Medicare and Medicaid, and you look at the legislation that was passed, and then you look at the legislation that was passed over the next 5 to 7 years following that relative to Medicare and Medicaid, we tweaked it. We changed it so that the package that we end up working with today is different than the one we started with back in 1965 and 66. I think that's going to happen with this legislation. So the tweaking process is part of the politics of what goes on in Washington. Lots of tweaking. So I'm going to skip over that. I wanted to point this out. This comes from a Commonwealth Fund, and basically one of the things that's embedded in the legislation, we were talking about this at our table tonight, is that there is an intent as part of the legislation to take money from the Medicare inefficient states and give it to the Medicare efficient states. One of the things that you'll notice is that, I don't have a pointer, but Wisconsin is, let's see, you're over here, right there in the, sort of right here, right? So that means that Wisconsin is one of the more efficient states. So in other words, Wisconsin is really good about using taxpayer dollars efficiently versus New Jersey, not very efficient, or Massachusetts or Louisiana. Those states are not very efficient, so the intent is to drive efficiency in those states by saying, well, we're going to take dollars away from you and we're going to give it to those states that are efficient, because as we cut everybody down, the folks that are already efficient are going to get hurt, so we want to protect them. That's one of the things that's embedded in the legislation. We also have these new entities that are being created. Accountable care, the rules haven't been issued on that. It's probably going to be coming out actually this week or next. We're not exactly sure what's going to be in there, but the intent is to create an organization, very unclear, that would be accountable for your care. So it's not just going to a primary care physician, it's really going to an organization who's going to provide all of your care. And there's lots of organizations that are trying to figure out how to do that. I would argue that whether or not this legislation gets through or not, that healthcare organizations should be working on becoming accountable care organizations anyway in their own way of looking at it. We need some good experiments because we need to become more accountable. We need to become more efficient. We need to become more effective. We need to have better quality outcomes. That's an imperative. That relates to that tsunami effect. If we don't, we're going to crush the country with additional dollars that are not going to solve the problem. There's also medical home, which is another program that's really more primary care oriented. So when you have a particular problem, let's say diabetes, you can go to a medical home and they have a comprehensive approach for taking care of you around your diabetes. Or there's another program around bundled payments. So in other words, we're going to pay Agnesian a set amount and then let them manage those dollars as a bundled payment. So there's all these different ideas about how we can become more efficient. This is a slide that I created about 7 years ago, and it really relates to an article that I read by Larry Downs, who is a thought leader in the IT industry. And I looked at his graph, which was describing information technology, and I said, oh, this applies to healthcare. And basically what it shows is that if you have a low volume, or you're the only person who provides a particular service, you can kind of charge anything you want. So if you're a ultraologist and you're the only ultraologist in town, you know, it's like, what are they going to do? Not come to you? You know, so you can charge what you want. Versus your name is Dr. Fickenscher and you're a family physician, and you know, there's lots of family physicians. You can't charge anything you want. As a matter of fact, there's a compression on what you can charge for general knowledge. This is what I call the healthcare value curve. And basically, what my point is that if I were to fall over and have a seizure and have a glioblastoma, I'd go over to the hospital and have my MRI scan, and they would diagnose me with a glioblastoma. Do you think that I would be pretty motivated to go see the best neurosurgeon I can find? And given the fact that I've traveled all over the country, do you think I would find the best one? Absolutely. Would I cash out to do that? Yes. Why? If I didn't, I'd be dead. Versus, I'm a 32-year-old woman. I'm having my 4th urinary tract infection in the last 8 months. And you want me to go stand in Dr. Fickenscher's office and wait for him to show up? I don't think so. I think I'm really busy too. Why should I do that? So and the problem is in healthcare, we tend to treat everything like a glioblastoma. And there's a bunch of stuff that are called products that we haven't figured out how to deliver. So I would argue that healthcare needs to start to differentiate between services and products. And that's a very important mindset change. It's taking off the goggles. That's what Walmart is doing. Walmart is going to provide products. They are not going to provide services. Now, there's no reason that Agnesian or Aurora or anybody else can't provide products. Matter of fact, I think they should. I think that'd be a smart move. So, here's what we can expect: consolidation, efficiency, globalization, virtualization. I do think we're going to be moving towards accountable care of some sort, so it's like get on the train. And I think the other issue is that we need to embrace the future. Matter of fact, I think it's really important. And we need to find Elvis. Now, so I started talking about this Elvis thing, and I had a good friend of mine, Mike Roizen, who works at the Cleveland Clinic, and he did an interesting thing. He sent me a mirror, and I usually have it with me. I forgot my mirror tonight. So I borrowed Donna's mirror, Sister Donna. She let me have her mirror. And the issue is, he sent me the mirror because he said, Kevin, I want you to look at it. You keep talking about finding Elvis. Look in the mirror. I want everybody to look in the mirror. Finding Elvis is all about us. It's not Kevin. It's not Sarah. It's not Bob. It's all of us. We need to figure out how to solve this problem. We need to step up to the plate. Because if we don't, we are going to cause significant stress for our society. We are going to bankrupt the country. Healthcare will single-handedly bankrupt the country if we don't figure out how to solve this problem at a national level. So my point is that we need to get involved, we need to get engaged, and we need to look in the mirror. And I would also submit to you that Margaret Mead said, never forget that a small group of committed citizens can change the world. Indeed, it is the only thing that ever has. Thank you. By the way, before I open it up for questions, I would offer one other thing to my healthcare colleagues: paddle like hell. So, I don't know, Donna, do we have enough time for Q&A?
We do have time for questions.
Okay.
I just want to say, and thank you to you, in value theory that I teach, we have a value we talk about as miniscence. And that means to miniaturize the essence of something. To someone who can take a very complex subject and make it seem simple. And that's what we just saw tonight. So thank you. I truly did that.
So I'm open to counter opinions. There's other perspectives, I'm sure, or questions, answers, discussions, debates. Put you all to sleep. Yeah, Sarah has a question.
If you would just wait till we get a mic and then we get the tape. Thank you.
If you would raise your hand, we can then see and come to you with the mic, okay? Go ahead.
You were discussing the paradigm that physicians and healthcare providers are going to have to kind of remove. They're going to have to remove this worldview. I'm kind of thinking that that's going to be an equal part of any patient as well, because we walk into that patient room kind of feeling a sense of this is an authority we cannot approach or that we cannot question. So I guess what would be your suggestion for people entering the office with that kind of paradigm on them as well?
Oh, I think very good point. One of the things that's also going to happen is that we are moving into a world where we need to take accountability for what we do. So, I went by it fairly quickly, but in fact, embedded in the legislation is that if you smoke, we can charge you more for your health insurance than if you don't smoke. And you know what? In today's world, we know if you smoked in the last 6 months. We know if you've drank in the last 6 months. I was talking with one of the people that does the testing for this. They know what particular beverage you probably drank, what kind of scotch you really like. It's that, I mean, it's that refined. So there is this issue of we as individuals need to take responsibility, not only for our personal health, but also for managing our care. I think we are moving from a rather paternalistic approach, which we've had for several centuries, to a period where, you know, you have to be responsible for some of the things in terms of how you take care of yourself. So, for example, if we have full insurance and we're providing you with medications, it would be very important for you to take those medications appropriately and to do it according to the regime that actually solves your problem. So that if you're diabetic, don't take your diabetic pills every other day because you're saving money. You have to take them every day because it controls your diabetes. This is an issue that I spoke to somebody who's pretty sophisticated 48 hours ago. One of my friends. Oh, I'm just taking it every other day to sort of save on the cost. I said, are you kidding me? What kind of game do you think you're playing? You're not managing your diabetes. No, so there is this element, I think, that is very important about the personal side. And it is going to change our paradigm. Other thoughts? Yeah, back in the back.
I have a quick question.
Sure.
Sorry, I don't mean to. Oh, it's Dr. Rosen. Oh, it's fine. This will only take 2 to 3 hours, so. You talked about earlier that we're going into an international economy.
Yes.
Are you seeing that applied to healthcare as lessons learned from Canadian and European healthcare systems? As we transition into the new healthcare system, are there lessons being learned from the way the Canadians and the Europeans transitioned to their current healthcare systems? And that's about it.
So that's a good question. What's interesting about the internationalization and globalization of care is that actually the United States is on the forefront of that whole issue. There are laws, for example, in the UK that prevent the providers from actually engaging with radiologists in India. It's very difficult, if not impossible. In the Middle East, you cannot move your data from Qatar to Saudi Arabia to Jordan. You cannot do that. So those kind of laws preempt or preclude the ability of the healthcare system to get creative around the globalization area. So the United States is at the forefront, along with a couple of other countries. I would say that Brazil is doing that now, partly because Brazil is modeled after the United States in terms of how it's structured. Why are we able to do that? Well, we're able to do that because the United States as a country is, I would characterize it as a much more entrepreneurial country. And there's a willingness to look at different kinds of models and different kinds of approaches. One of the things that's been interesting is McKinsey did a study of outsourcing and globalization of the workforce. What's interesting is that the first things that were outsourced were things like hard industries, so timber. Now, we outsourcing timber? Well, yeah. In the United States, we outsourced the growth of trees and the cutting of timber to our friends to the north called Canadians or to Brazilians. We did that a bunch of years ago. So we've outsourced timber there used to be a lot of timber mills in Wisconsin. Is there one here anymore? I don't think so. So that's what was first. The second thing that got globalized was back office functions. So if I can provide a billing service, and I can do that in Bangalore more efficiently than I can do it in Fond du Lac, and I can do it for a fourth of the price, I'm going to do that. And there's lots of lessons to be learned on how to do that, because it is not just passing it over. There's a whole process issue that needs to go into play so that you maintain quality and all that. The final thing is the professions, the ones I was talking about, radiology. So what do you think is the fastest growing outsourcing capability in India? Anybody have a guess as to what it is? Legal services. Lawyers. I personally, well, I'm sure there's going to offend somebody here, but I think that's a good idea, But it's going to happen to the professions. It's going to happen to medicine. It's going to happen to law. Architecture is another one that's being outsourced. So that there are certain pieces of what we do, that product side of what we do, that can more easily be outsourced or done in a different way. And that's what I'm arguing. If it's more efficient, more effective, if it reduces cost, increases quality, and enhances service, I think that the healthcare system will naturally move there in the United States. Yeah.
I believe Sarah brought up a great point, this idea that patients need to take a role in their own health care.
Yep.
My concern is that if we go towards treating the urinary tract infection as a product, will patients see less of their health care providers? That's my first part.
Well, I mean, here's the issue. I pointed out that we're going to lose about a third of the providers over the next decade. So we better figure out a different model for delivering the care than the current model. I would argue very vehemently, as a matter of fact, I'm giving a talk to the Federation of State Medical Boards in Seattle at their annual meeting in 2 weeks on this very topic, that the model for how we deliver care, so why is that important? The Federation of State Medical Boards is the group that creates the licensure for physicians in all of the states. So they're the ones that control who can do what. So for my license, I actually have my license in Wisconsin. The Wisconsin State Medical Board determines what I can do, okay? So that's the reason that's important. I would argue that we need to have a different model. That if we continue with the current model, which we've used for several centuries, there's no way we can deliver the care. So it's incumbent from my perspective, not on consumers, but on the professions to figure out how to do that more effectively. So what are going to be the rules? What are going to be the ground rules? And if we create the right kind of ground rules, I can point you to the literature that shows that a nurse practitioner under protocol can do 95% of what a family physician does.
I would never argue against that.
Okay.
But my concern is the health illiteracy that we see in this country. I think you're speaking to a room of educated.
Yes.
Or hopefully getting their education.
Yep.
And I don't know that we're necessarily the problem, but there are quite a few, parents of my students who don't understand when they need to take their diabetic pills or why. How do we as a society, and how do you as a health professional, and the future nurses in this room, how do we help combat the health illiteracy if we're going to more of a product delivery model? Great question.
Great question. Now, in the 60s, we did things other than what I suggested that we did. So we organized and we created protests and all that. I was a big fan of Saul Alinsky. Okay, Saul Alinsky lived in Chicago, and his mantra was, you recruit to a cell, a C-E-L-L. That was his, and that was the mantra for those of us who were organizers of political action groups back in the 60s. Now, what does that mean? What it means is that you have to recruit somebody on where they are, not where you are. One of the problems we have in healthcare is that we're trying to recruit people who have problems to where we are versus where they are. And we need to rethink that model. So that's the reason that's the reason I gave you the example of using Twitter as a tool for controlling AIDS or diabetes. It's a whole different way of thinking about how I'm going to deliver care. I would also submit to you, having done my residency in the Bronx, which is a population that is very impoverished, not very educated, that population is very sophisticated when it comes to getting health care. Just as sophisticated as the population that lives in Fond du Lac. So I think we should not underestimate the intelligence of the American people across the board. Now, does that mean that we need to, I think we need to do a much better job of education. Diabetes is a classic example. It's not about necessarily getting your insulin, it's about educating people properly. The best way to manage adolescent diabetics is through education programs in schools. There's a lot of data around that. But we don't support that. We don't pay for it. Well, I can tell you, if I'm the head of an accountable care organization and I've got 200 and some kids who have diabetes in my community, I'm going to be doing that because it's going to be more effective. They're not going to be coming to my emergency room. So again, we have to rethink our model, and I think it is incumbent upon us to rethink how we would deliver the services. So you raise a very good point. I don't necessarily have answers. Let me give you one other example. There was a study done in Massachusetts, a really good study, scientific and everything, that they did on congestive heart failure patients. And basically what they did is they had individuals step onto a scale in the morning, first thing out of the morning, and step off the scale and answer 5 yes/no questions. Now, why did they do that? Well, what we know is that people who have congestive heart failure go into congestive heart failure about 72 hours before they show up in the ER. So if we can predict that they're going into congestive heart failure and prevent them from coming into the ER, we will save gobs of money. So what happened? People stepped on the scale, they stepped off, they answered 5 questions, the data went into the computer. Hey, Kevin, better take your diuretic today, your weight is up a little bit, you're having a little bit of dyspnea, okay. I take my medication, I don't show up in the ER. What they showed was a dramatic improvement in the care of congestive heart failure patients. There was a drop-off of literally 70% of people using the emergency room. So you'd say, boy, let's deploy that program. Well, what they did in Massachusetts, now this is 5-6 years ago, is that they pulled the plug on the study. Now, why did they do that? Because the hospitals were losing money. Seriously. So what that shows you is, I think, something else that we need to be talking about is it's not the money, it's the money. The American healthcare system is really, really good at responding to the incentives. I think we need to be talking about the incentives of the system. And if we change the incentives, I can tell you healthcare will move there. They're very good at figuring out where the dollars are. So if we put an emphasis on prevention, if we put an emphasis on education, if we do some of the things that we know will save money, healthcare will move there relatively quickly. It's been shown repeatedly. Yeah.
You've talked about globalization and consolidation.
Yes.
More globalization than consolidation. And the assumption in your talk is that those are both good things. And I think the basis for that assumption, I think, is that you believe those both will produce cost savings. I would like to propose a different formulation here, and that is that disintegration may in fact be the more efficient, less costly, and higher quality approach to the problem. And I just want to get a reaction.
Well, I'm willing to consider that. The data would not support that. I mean, and by the way, when I talk about consolidation, this isn't Miami. I mean, Wisconsin's not Miami. So Wisconsin's already done a lot of consolidation. Okay?
A huge amount.
So there's not much more you can do in this state. There's a little bit you can do. But it's not the same as Miami or, gosh, I could take you to all sorts of places that are like cowboy land in terms of healthcare. So on that front, that message is really probably for other areas. But is there efficiencies that have been brought to bear in Wisconsin? I think the data shows it. I mean, if you look at those states that are on the left-hand side that are efficient,
Can I jump? But I mean, isn't the efficiency that you show there a product of traditionally low reimbursement rates? Wisconsin has a low reimbursement in part because when Medicare was passed, the reimbursements were based on historical reimbursement rates, and they received percentage increases. I'm not trying to denigrate Wisconsin's healthcare
but
system.
in part. But I can tell you right now, if you look at the total cost of care, if you do coronary acute myocardial infarction, which is a heart attack, the cost in Minnesota is the lowest in the country on an average basis. The highest is Miami.
The cost or the price?
Cost. Price is not quite the same. The cost is dramatically different. I mean, it's like 3 times as much in Miami as it is in Minnesota. Now, why is that? I would argue, from my perspective, because if you look at those states, and there is some evidence to support this in the Dartmouth studies that have been done, if you look at those states that are on the left-hand side, it is the upper Midwest. And that's the influence of the Mayo model. The Mayo model is the predominant way that healthcare is delivered in the 6 or 7 states in the upper Midwest. I mean, South Dakota, North Dakota, Minnesota, Wisconsin, Michigan even. And I think that it shows pretty clearly that there is some efficiencies that get created from that particular model. That's the reason that accountable care as a concept is built around that kind of a delivery model. Now, you're absolutely correct that there is this historical issue that the payment system was put in place and it was based on history. And so New York City got more payments than Madison because, you know, they had to pay more for their rent or something like that. Is that fair? Well, that's what they're saying we need to rectify under this new legislation. I think there's a lot of lessons that can be learned from the upper Midwest. I happen to be a big fan of what's going on in this part of the geography of the country. And actually, I believe that accountable care, in terms of the concept, will be driven by the models that get created in the upper Midwest. I'm looking to this part of the country to be the leaders. Does that answer your question, sort of? Sure. Yeah. I don't think that disintegration, I mean, the data shows pretty clearly that if you have just a bunch of independent people, that it's not going to be very efficient.
My concern was this, that in the long run, consolidation can be a problem.
Right.
At some point when you have monopolies or close to monopolies, the ability to improve healthcare quality diminishes due to the lack of responsiveness on the part of the monopoly providers.
Okay.
And my concern is when you have I mean, I think in Wisconsin there's lots of competition among systems right now.
Yeah.
But you referenced early in your talk that you thought Milwaukee had consolidated a great deal, and there would be more of it. So my question is, that was sort of the thrust of my question.
Sure.
At what point is that consolidation detrimental to both cost questions and quality questions?
Okay, well, that's a fair question, and I don't know that I have a specific answer for you, but I would suggest that we are a long way from monopolies. Long, long way. Look at other industries. We're not even close to what goes on in the automotive industry. We're not even close to the consolidation that exists there. We couldn't even dream of what's happening in telecommunications. I mean, basically, you have now AT&T and Verizon, and also RANs. We're not there in healthcare. We're not even close to that. There is no equivalent to an AT&T in healthcare. So I think that we have a ways to go before that concern becomes, can carry water. Over here? Yeah, over here.
In the healthcare discussions that happened before the bill was passed, there were a lot of people who did not want to see universal coverage, that their dollars would pay for the uninsured. And coming from a moral perspective and also a human rights perspective, I, of course, would favor that all peoples be insured, even those millions currently not included. My question is, in your travels around the country, is that the attitude that you have found, or are people really, or do people really have a big enough heart to include the uninsured?
I think that, so my feeling is that as I talk to audiences, I was just in Utah and talking with similar type audience in Utah just 4 days ago. And I would say to you that the American public does, in fact, believe that we should have access to healthcare services. I mean, Massachusetts has demonstrated that, where they've gone from 85% to 97.5% in a relatively short period of time. And the people of Massachusetts like the program. The issue, so let me just share a little statistic with you. I don't know if everybody had the chance to read. I just wrote this down. I just remember this. So in Wisconsin, this is a poll that was just released yesterday. 59% of you believe that the state budget is a major concern. 67% oppose reduction in aid to municipalities. 66% are opposed to firing state employees. So the issue is, if we did a poll here, I bet you that we would come up with a fairly high percentage of people that take your position that we should provide care to everybody. I think a lot of people would support that. The issue then becomes how we're going to pay for it. That becomes the issue. That's part of the reason that I sort of harped on the notion that I think we need a different model. We need to follow the money. It is about the money. If the healthcare system, if we create the right incentives, will do the right things. We need to get creative and try to figure out what the solution to that problem is so that we can become more efficient, more effective, and deliver more care for the same amount of dollars. Because there's only so many dollars in the bucket. There's only so many dollars. Yeah.
If the United States is entrepreneurial,
yep,
and if we follow the money, the bottom line,
yep,
why hasn't the healthcare system gotten onto the alternative and complementary medical world where there's $1.3 billion that's spent every year out of pocket, not insurance, anything else? Why haven't they gone there?
Because the incentives of the system, I hate to be, my perspective is the incentives of the system are pass a tube, get a payment. Do something to somebody, get a payment. That's the incentives of the current system. If I'm a family physician, I don't get paid tiddlywinks if you're a smoker, and I sit there for an hour to talk to you about why you shouldn't smoke. I don't get paid. If I do something to you, I get paid. The incentives of the system, I think, are one of the core issues. That's the reason we have a lot of waste.
Well, why haven't the insurance companies then jumped onto that incentive and say, okay, we're going to insure this?
Who wants to go first? Cigna, Aetna, Blue Cross of Wisconsin? Who wants to go first?
Well, they know the money's there. Why don't they?
Well, I'm just, because one of the things that happens is if you sort of push in on the balloon over here, it pops out over here. And that's the reason there needs to be a holistic approach. We need a holistic revisiting of how we do this, which was part of what was behind this legislation. Now, we can argue about whether they were successful. I think that they did some good stuff. They did maybe 80% of what we needed. The 20% that's missing is important stuff. So, for example, they totally bypassed the reimbursement model. They didn't address that issue at all. And so when people say to me, what do you think of healthcare reform? I say, well, this is when I get cynical. They took all the healthcare people, they put them in a rowboat, they shoved it out into the pond, they took out their shotgun and blew a hole in the bottom and said, good luck. Because the current system is still paying us the old way. That makes it worse. So part of the issue why there needs to be this discussion around accountable care, primary care medical home, bundled payments, all these new ideas, is that I believe that we're on a path where we got to respond because we're sinking the boat faster than we used to sink it. So it is an issue about how the reimbursement model is the core problem. And the issue does become who's going to go first. You know, do we want the doctors to go first? No, no. Let's let the hospitals go. Oh, the hospitals, no. Let's let pharma go first. No, the medical device. See the problem? But now, by the way, I do believe it's solvable. I really do. Yeah.
I just wonder what your opinion is of there has been a lot of talk about competition in healthcare.
Yeah.
And the fact that it is supposed to lower cost. Is that been
borne out in data that shows that that in fact happens. And part of the reason that I'm asking about that is, I don't know if you knew or remember this, but I think it was in the 70s and 80s in Wisconsin we had something called the Rate Setting Commission.
Right.
And they approved rate increases
Right.
in hospitals. They approved new equipment. They approved hospitals to be built.
Micromanaged everything.
Yes.
Yes.
And that was sunset in, I don't even remember, in the 80s, I think. But now it looks like we've gone way off the deep end in the other direction, that every healthcare agency in town now has to have an MRI +2,
Right.
just for the heck of it. And, you know, or for instance, we have, it's here in Fond du Lac, we have St. Agnes Hospital. We do have other healthcare systems, but we only have one hospital. A community nearby built another organization built another hospital. So we had one hospital that was 2/3 full. Now we have two hospitals that are each 1/3 full.
Right.
And I can't believe that that makes costs go down, because it still costs a lot of money to run those institutions. So
Right.
what's your opinion about that?
I think, so you're absolutely correct. The competition model that we have in place today isn't really driving down costs. If anything, it's exacerbating them. And part of the reason that that occurs is that we have, quote, competition, but we don't really have competition. Because if you're going to have competition, you have to have transparency. If I'm going to buy a television from Best Buy versus buy it from Walmart, I can go out and look at what the cost of those two televisions are. Or better yet, let's take my company that I'm just leaving, Dell Computers. That's who I've been working for, okay? All of you who buy Dell Computers, almost all of you go out and not only look at Dell, but then you look at HP. And some of you look at IBM as well. Or not IBM anymore, Lenovo. So those are the top 3 producers of computers. And there's lots of competition around that, but it's because the cost is so transparent. What do you think the margin is on a laptop? Any guesses? 1.5%. So how do you make money? You sell a lot of them. That's the only way you make money. You sell gobs and gobs and gobs of computers. That's the reason Dell is a successful company, is because it sells more computers than anybody else in the world, but it sells them at margins that are like this. Now, it's getting beat up on Wall Street because of that, but there's transparency. In healthcare, we don't have transparency. There's no way to, with all due respect to the local healthcare system, there's no way to transparently compare what goes on at Agnesian versus what happens at Freighter versus what happens at Oshkosh. The data isn't there today. Under this legislation, the intent is to move in that direction. And if you have transparency, I think that competition will become more of a reality in healthcare. That's my opinion.
Is it also partly because the individuals if they're getting insurance through their employers, they don't get to make that decision? It's being made for them? For instance, if they contract with a healthcare agency versus one?
Well, yeah, one of the issues, and there's a lot of debate about this issue, is how to engage consumers. If you are paternalistic and you do everything for them, they will act like children. That's what we've done. Now, let's take another issue that's very fond and the debates that I participated in over the last 20 years. I remember sitting in board meetings with large companies where the discussion was, oh, we can't have the employees take over responsibility for their retirement funds. They wouldn't know how to manage them. How many of us manage our own 401ks? How many of us have these defined very few of us have defined benefits, right? Does anybody have defined benefits anymore? You're lucky. Is there anybody? One. We're all managing our retirement. And the data is very transparent. If I don't like the results of one fund, I move my money. And I can manage it, or I hire somebody to do that for me as a proxy. So there's lots of ways to manage it. In healthcare, we don't have that freedom under the current system. the intent is to do that and to move in that direction with the transparency of data. So I think that's one of the core problems that you're touching on that is really crucial, and it is about follow the money. Well, it's getting late. Thank you very much. I'll stay around if people want to talk about other issues. Thank you very much, and hopefully this has been helpful.
Thank you again, Kevin. I invite any of you who can to come again tomorrow as we continue this dialogue. Have a good evening.